Well, thank you very much for the kind invitation to come and speak here. And as indicated, what I'd like to do today is set forth some of our plans to develop a total body PET scanner. And what I want to do in the presentation is really step you through some of the motivations that took us in this direction, talk a little bit about our approaches to this project, and also about some of the applications that we see this opening up. This is a big collaborative project. It's led by UC Davis, but it also involves collaborators at the Lawrence Berkeley National Laboratory and also the University of Pennsylvania. We are getting a lot of input from industry. We spend a lot of time talking to the imaging companies, and we have a lot of people helping advise us there. And we also have a large medical advisory team as well. So I'm going to start with the real basics because I sort of want to set up some of the challenges and opportunities that are ahead. So we'll start with the basic PET physics slide here, just to remind us that what we're trying to do here is to detect, in coincidence, the two 511 keV annihilation photons that are produced following positron emission. And in the PET scanner, what we're trying to do, of course, is to detect these two annihilation photons. And so we want detectors that have extremely high efficiency. And also, we're going to be very interested in spatial resolution. So we want relatively small detector elements so that we can appropriately localize those annihilation photons. So really, sensitivity and resolution to first order are the two parameters that we're always striving to maximize. And so if we look inside today's current scanners, they're almost all based on scintillation detectors, using dense scintillator materials to convert those energetic annihilation photons into visible light, and then turning that visible light into an electronic signal using some form of photodetector. Classically, that's been the photomultiplier tube. Old vacuum tube technology still used commonly today. And a configuration like this frequently, where you have a segmented array of the scintillator read out by multiple photomultiplier tubes. And so when the 511 keV photon comes in, interacts, produces a flash of light. And depending on how you segment this array and the reflector materials you use, you can control the distribution of light onto the photosensors and obtain position information. Increasingly today, we're moving towards solid-state detectors for the readout of the scintillator array. So devices such as silicon photomultipliers shown here, very compact form factor, but a large number of channels, as you can see, that need to be read out. So that's the classical approach. And of course, as you well know, we have fantastic multimodal systems available now in the clinic, PET CT systems initially, that allow us to really correlate the anatomy with the molecular imaging information that's coming from PET. And then more recently, of course, the advent of PET-MR, the ability to put a PET scanner inside the magnet and simultaneously acquire positron emission tomography and magnetic resonance images. So we have this fantastic technology, so aren't we done? Can't we shut up shop and go home at this point? And the answer, of course, is no. There's still a lot that needs to be done and can be done. And so if we look from the PET perspective, there are really four major performance metrics that we tend to look at. We've already mentioned spatial resolution. We would, of course, love to improve the spatial resolution that we can get in clinical PET. I'm going to spend a lot of time today talking about sensitivity, which is an area where I think there are massive gains still to be had. Timing resolution is another huge focus in PET right now because it actually plays into the sensitivity. If we can constrain the event using time of flight information, we can get an effective increase in sensitivity that's quite dramatic. And some of the new detector technologies and new scintillator materials that are coming along offer great promise in that regard. And of course, we're also always interested in having good energy resolution, knowing the energy deposited by the event in the detector, because photons that have scattered inside the body will have lost some of their energy, and this provides our primary mechanism to reject scattered radiation. So let's talk for a moment about spatial resolution first. What spatial resolution can we ultimately hope to be able to obtain for whole body human imaging? And there's a couple of physics factors that are going to eventually limit us. First of all, positron range, the fact that the positron travels some distance from the site at which it's produced before it annihilates with an electron to produce the back-to-back annihilation photons that we subsequently detect. And the range that matters here is this distance shown by the blue line here. And the positron range depends on the energy spectrum of the emitted positrons. So fluorine-18, which is the most commonly used radionuclide for clinical PET, we're fortunate that that has a relatively short positron range. It has low-energy positrons. They don't travel far in tissue before they annihilate. And so if we look at the point spread function, and we have a millimeter scale bar here, the point spread function caused by the positron range distribution is quite narrow, well below a millimeter. However, if we look at some of the more energetic radionuclides, and if we look here at oxygen-15, this emits much more energetic positrons. And you can see in this case that the point spread function due to the positron range starts to get up into the millimeter range. So with the highly energetic radionuclides, we certainly would have to consider positron range as a possible limiting factor. And you can certainly see that in some of the high-resolution preclinical scanners that have been built. You can see this effect when you use the higher energy positron emitters. You can see degradation in the images due to this effect. The other physics effect that we have to deal with is the non-collinearity. And this arises from the fact that when the electron and the positron annihilate in tissue, they're not completely at rest. And therefore, in order to conserve both energy and momentum in that annihilation reaction, the two 511 keV annihilation photons don't come off exactly 180 degrees apart. They have a distribution around 180 degrees that's roughly plus or minus a quarter of a degree. And the impact of that is that we misposition events in the reconstruction. So it's greatly exaggerated here, but it helps you to understand what's going on. If we have an annihilation point here, and here are two annihilation photons in red that are not 180 degrees apart, as you can see, and we detect them in these two detectors here, and we draw a line between the two detection points, you can see the line along which we would reconstruct that event misses the actual annihilation point. So we have a blurring due to this effect, a mispositioning due to this effect. And this mispositioning gets worse as the detectors get further apart. So in a clinical scanner where we have to have a ring diameter of approximately 80 centimeters in order to accommodate the entire body, this blurring factor is close to 2 millimeters. So this is a pretty significant limitation in terms of getting very high spatial resolution for human PET imaging. So if we take fluorine-18 labeled radio tracers, which is what we commonly use in the clinic, and look at the positron range, the non-collinearity effect we just mentioned, we also get some scatter inside the detectors that degrades our spatial resolution as well. But as you can see, that's a relatively small effect. And so you can see in a clinical scanner, we're really dominated in terms of the underlying physics by the non-collinearity. So even if we built detectors that had sub-millimeter spatial resolution, we would end up with images on the order of about 2 millimeter resolution because of these various factors and dominated by the non-collinearity. Now, clinical scanners today are not at this level of resolution. They're typically in the 4 to 6 millimeter resolution range. And one of the reasons that there hasn't been a great push to improve the spatial resolution further, even though we have detector technologies that are capable of it, is really that we don't generally have the underlying counting statistics to support that level of spatial resolution. Which really brings me on to the main topic of today's talk, which is that we also need to have very high sensitivity. And so I'm defining sensitivity here as the fraction of the emitted 511 keV annihilation photon pairs that get detected. And it depends primarily on two factors, one being the efficiency of the detectors, what fraction of the annihilation photons that pass through the detectors are actually absorbed and converted and detected. And then also, because of course the radiation is being emitted isotropically, the solid angle coverage of the scanner. How much of the solid angle around the patient are we covering? So this is the way we currently do whole body PET scans. So the patient is stepped through a scanner that typically covers an axial field of view on the order of about 20 to 25 centimeters or so. And so at any one time, only a small fraction of the patient's body is actually in the sensitive region of the scanner. So in the PET field, of course, we like to trumpet the fact that we have fantastic sensitivity. We like to say that PET provides the most sensitive, non-invasive molecular assay of the human body, which is a true statement, I believe. But it's also true that every single study we do currently in the clinic is limited by the statistics, the counting statistics, how many events we detect, and or radiation dose. So we are very much starved for counts. That's why our images tend to look noisy, and that's why we tend to have to reconstruct at fairly low spatial resolution. So current scanners really, when we're looking at the entire body, do not maximize the sensitivity that's possible. In fact, you can easily show that we collect less than 1% of the available signal. So we're giving the dose to the patient, and we're only collecting less than 1% of the signal. So that's really, really wasteful. So the question is what to do about it. Well, the answer is not rocket science. It's really pretty straightforward. We've got to improve the solid angle coverage around the patient, because that is the thing that's leading to such poor sensitivity when we're trying to image the entire body. And so if we could build a scanner that really surrounds the patient with detectors, and I'll show you some simulations in a moment, they suggest that we would get a 40-fold improvement at least in the effective sensitivity when we want to scan the whole body. Now sometimes, of course, we don't necessarily want to look at the whole body. We only want to look at a single organ, for example, the brain or the heart. And in that case, the gains are substantially less because that organ already fits in the field of view of currently available scanners. But we still get a boost from that additional solid angle. And so even in the case of imaging a single organ, we can anticipate about a 4- to 5-fold gain in the sensitivity. And the other key point about doing this is not just the sensitivity gain, it gives us a different way of looking at the body, because for the first time, we'll be able to track the kinetics of our traces in every single organ and tissue of the body simultaneously. So we'll be able to see everything we injected and everywhere where it goes dynamically. And I think probably some of you will appreciate that opens up a lot of interesting possibilities. So as I mentioned, this big sensitivity gain comes from two factors when we want to look at the whole body. The first factor is that we're covering a lot more of the body with detectors, so we're seeing the entire body rather than just part of it. And the second factor is that, of course, that for any one detector, we're increasing dramatically the solid angle by the large array of detectors that it's in coincidence with. So that combination of those two geometric factors leads to a big increase in the overall sensitivity. Now, this is not a new idea. It's been around for a long time. We've wanted to do this in the field for many decades. You can see ideas along these lines going back all the way into the early 1990s. And there's been quite a lot of simulation work in this area. There's even been one scanner built by Hamamatsu that actually had a 70-centimeter axial field of view. But unfortunately, that system had some other challenges related to count rate performance that really limited its ability to realize these gains in sensitivity that we've been talking about. So many people have been thinking about this for a while, so why has it not been done? Well, I think you can appreciate there's some significant challenges in doing this. It's a very large-scale project in terms of just the number of detector elements we're dealing with, the numbers of channels of electronics, the amount of material. Issues like power consumption and temperature control become quite challenging at this scale. So we're at a complexity level that's at least an order of magnitude higher than with current systems. And then if we're going to have this high sensitivity, we'd really like technology that can take advantage of that. So we'd like to have good time of flight and depth encoding information, and I'll explain why in just a little while. And if we've got better counting statistics, we can also anticipate being able to push to higher spatial resolution for some applications as well. The other piece that's quite hard and challenging is the data side of things, how we handle these massive event rates in real time, looking for coincidence timing across all of these detectors at the few hundred picosecond level. This is not trivial, how you sort that data, get it out the scanner. and then how you, of course, store it and process it in terms of the reconstruction. So lots of interesting challenges on the data side as well. And then a not insignificant challenge at the bottom here, which is how you raise the money to actually build one of these things. So first, I'm going to show the simulation data that's quite old data now that helped make the case that this was worth doing. And so what we did for this is that we took an existing clinical scanner, which is, in this case, the Siemens MCT scanner, for which we had a really good simulation model that had been carefully validated over several years with experimental data as well. And so we felt we had a model that we had a good understanding of and that we had some confidence in. And then we asked the question, if we extended that scanner using the same detectors, the same electronic architecture, if we extended that scanner to just over 2 meters long, what would be the performance? So we did Monte Carlo simulations using the Monte Carlo code SimSet. We also ran simulations in another package called GATE as well, just to confirm the findings. And I'm going to summarize just in 2 slides a lot of data here. And the metric that we like to look at in PET is something called the noise equivalent count rate, which accounts for the fact that when we get an event, it's not always a good event. Sometimes the event has been scattered, so it's mispositioned. Sometimes it's a random or accidental coincidence where we get 2 annihilation photons from different decays that happen to occur within the coincidence timing window. And so we have to account for these bad events as well when we're looking at the effective sensitivity. And then on top of that, we have another formulation of this that comes from Maurizio Conti, where we also take into account the timing resolution of the scanner and how well we can constrain the position delta x based on the time information. So that also gets folded into that. So for those of you in the field, you'll know this. For those of you who are not, don't worry too much about the details, but it's essentially a noise-effective sensitivity that we're measuring here after we take into account the different sources of noise in our data. And so this is the current clinical MCT scanner. In red here, this is activity concentration versus this measure of sensitivity on the vertical scale. And for the much longer scanner that we would like to build, we're projecting this massive performance increase here. And as you can see, as you go to high activities, eventually you saturate, and then the count rate and the sensitivity goes down. That's because of dead time and pile up in the detectors in the electronics. But typically, we're operating down in this range in a clinical scenario. And this particular simulation was for this phantom here, which was a very crude approximation of an adult human body, a 27 centimeter diameter cylinder, 2 meters long, uniformly filled with activity. So this encouraged us that there was a huge performance gain to be had. So if we actually go and look at the effective improvement in sensitivity for that phantom, it's about a factor of 44. So when I say that we can get a 40-fold increase in sensitivity, that's where that number is coming from. Now, of course, it's context dependent. So if we look at other objects, the sensitivity gain will be different. So if we're interested in pediatric studies, where we would anticipate a smaller object, maybe 20 centimeter diameter by 70 centimeters long, now the gain is about a factor of 20. And as I already mentioned, if we look at single organs, either brain or heart, then our gains are more in the 4 to 5 range. So we're predicting these fairly large improvements in sensitivity. And so how could you anticipate using that additional sensitivity? And there's many different ways you can use it, all of which have some interesting implications. So the most obvious thing, of course, is that you can just get a lot more counts. You get a lot more data. And so if we have a 40-fold improvement in our sensitivity, you'll get roughly the square root of that as your improvement in signal-to-noise ratio. So about a 6-fold improvement in signal-to-noise ratio. So if we got much better data, that allows us potentially to reconstruct at higher spatial resolution. So that might be a rationale for then improving the spatial resolution of PET, which could lead to our ability to detect smaller lesions or detect lower grade, more subtle disease. It also gives us much better statistics for doing dynamic studies and kinetic modeling as well. So that's one way you could use the sensitivity gain. Another thing, as I've indicated, of course, is that we're going to see the entire body. So now, instead of just being able to look at time activity curves in the brain, for example, we'll simultaneously be getting time activity curves for the heart and for the liver and for excretion of the tracer through the kidneys into the bladder. We'll see the whole system. And so that's very nice because we'll be able to model, for example, the distribution of new drugs and look where they go over time. It also means that we could actually measure the blood input function, so the delivery of the tracer to the different organs, which is a critical part of kinetic modeling. We'll see that in every scan because the left ventricular blood pool will be in the field of view for every scan we do. Another thing that is quite interesting with this approach is that we're going to have a much bigger dynamic range. We're not giving anything up at the high end, so we can inject the same activities we're currently injecting and manage those activities, but with the additional sensitivity, as the radionuclide's decaying, we're going to be able to scan out for much longer in time. So with carbon-11 labeled tracers, carbon-11 has a 20-minute half-life. Typically, right now, we're limited to about an hour or an hour and 20 minutes of data before the signal quality is so poor because of the decay of the radionuclide. But now, with this extra sensitivity, we can go out roughly 5 more half-lives, so we can get beyond 3 hours with carbon-11. And with fluorine-18, which we use a lot clinically, instead of just looking a few hours out, we could potentially even bring the patient back the next day and look at very late kinetics, 18 hours later, and still have enough signal to see it. And where it gets really interesting is some of the long-lived radionuclides, for example, that are being used to tag cells to look at cellular-based therapies, where we'd like to be able to watch those cells and see where they are in the body over periods of several weeks. Now this will be possible with zirconium-89. We may be able to go out over a month rather than the 10 to 12 days we currently can go out with this radionuclide, because again, we've extended the dynamic range. So we can really image out much later as the radionuclide's decaying and still get adequate signal. Another thing we could contemplate doing, and I should emphasize, we can't do all these things at once that I'm talking about. So there's different ways you can use this 40-fold increase in sensitivity, but you can't have everything, so you choose how you're going to use it. So another way you could use it is just to scan much faster. So you could inject the same dose we currently inject, get the same statistics we currently get, but instead of doing a whole body scan in, let's say, 10 minutes, you could do it in 15 seconds instead. So that's very interesting because it means for the first time we could do total body PET imaging in a single breath hold. Basically, the patient would just go in the scanner, 15 seconds later, we've got the same quality of data that it currently takes us 10 minutes to acquire. And if you can image in a single breath hold, of course, that's great. It would reduce respiratory motion. It also means we can match PET to the CT because the CT is also taken during respiratory breath hold as well. So in terms of that spatial registration, things get much better. And without the motion of the patient, we think we should be able to get higher spatial resolution as well. And the fact we can capture high quality data in just a few seconds means that we're going to have great data for doing whole body tracer kinetic modeling as well. Another area where we can use this increase in sensitivity is one that I'm sure many of you already thought about, which is that we could just inject far less activity. So again, we could think about injecting 1/40th of the activity that we currently inject for a scan, and yet get the same quality images that we currently get. And so that would take us down to radiation dosage for a whole body PET scan on the order of about 0.15 millisieverts. We're currently in the 6 to 8 millisievert range typically for a PET scan, so that dramatically reduces the dose. And I'm sure I don't need to remind people here that the annual background worldwide is on the order of a couple of millisieverts or so. And for those of you that flew to the West Coast from Europe or the UK and are returning there later, you're going to get an additional dose just from that flight of about 0.1 millisieverts. So we're getting into the range of doses that are things that we commonly experience just by attending conferences such as this one. And our hope there is that we can start to use PET with minimal risk in new populations, and particularly the adolescent population, where there's a lot of interesting health-related questions that I think PET could contribute greatly to if we can control the radiation dose to a level that's very acceptable. And also with that reduced radiation dose, it gives us the possibility to study chronic disease much better than we currently can with PET. So currently, we are limited by radiation dose for how many PET-CT scans a subject can receive. It's a small number right now. But now we could do 40 scans in an individual for the same dose that they currently get with one PET-CT scan. So this allows us to track the trajectory of a disease and the effect of an intervention over time much more effectively. So these are some of the exciting different ways we can use such a big gain in sensitivity to do some new things, we hope. So now the question is, how do we get from an idea, which on paper looks reasonably plausible, simulation data looks quite encouraging, how do we actually prove that this is going to change the way that we use PET both in research and eventually in the clinic? And so if you go buy a PET-CT scanner today, we can quibble about the numbers, but you're roughly in the $2 million kind of range. And so the big question is, what's this guy going to cost? And how do we get enough funding to actually build an initial prototype to actually demonstrate those performance gains that we've been talking about? So fortunately, the NIH has this program called the High Risk, High Reward program that has a number of different components to it. But the one that we focused in on was this Transformative Research Award. And it supports innovative, unconventional, we've been called that many times, risky, that's definitely us, untested, that's us, projects such as this. And the other nice thing is we're instructed to focus on significance innovation without providing preliminary data, which again, we couldn't other than the simulations, there's not much else we could show at this point. So we were fortunate enough to receive one of these awards about 6 months ago, jointly funded by NCI, NIBIB, and the Office of the Director, that's going to now allow us to actually build the first prototype system. And we actually have a couple of strategies in terms of how we're going to do this, both a shorter term and a longer term developmental strategy. So the shorter term strategy is the low risk strategy because it's really critical with the level of investment in this system that the first system works really well. It's reliable, it's robust, and you can imagine with so many channels of detectors and electronics, we need to be really careful about the design, the manufacturing of this device. And so we're working closely with industry to essentially extend existing detector technology and electronics that's been in the field for several years, is well understood, and extend the axial field of view to develop a very robust first prototype system. At the same time, we recognize there are opportunities to greatly improve the performance based on new detector technologies coming along and the fact that we're going to have much better counting statistics, which means that we could push to higher spatial resolution. So we also have a program developing new detectors and electronics that will integrate some fairly advanced capabilities that I'll talk about in a moment, higher spatial resolution. And we're also interested in maintaining as much information in the data as possible. So in current scanners, we actually throw away a lot of information as the data is being sorted, and so we don't have access to that. For example, in most scanners, we don't have access to the individual energy that's registered for each event. And also, events are typically formed into coincidence pairs in the sorting electronics, and so we have no flexibility, for example, to change how we handle the timing information after we've acquired the data. So one of our other goals is to keep as much information as possible with the data that's streaming out of this scanner so we can apply lots of interesting, sophisticated approaches for handling that data afterwards and reconstructing it. So the first step that we have taken is to design and build what we call the mini explorer. So we need to quickly get to some proof of concept data and to get to a geometry that starts to allow us to explore some of the challenges and some of the data correction strategies that we want to employ. So what we've done initially is we've taken detectors from a clinical scanner and we've reconfigured them into a smaller bore but a much longer axial field of view so that the geometry here is just a scaled down version of what we're eventually proposing for human imaging. And this in its own right has some interesting applications because you'll probably get a sense from this picture that it's just the right size to do studies in veterinary medicine or in non-human primates. And at Davis, we have one of the best vet schools in the United States, and we also have one of the 7 national primate centers that NIH supports. And so this is a great environment, in fact, to actually use this device to prototype some of the eventual human applications in animal models first. So not only is it a good testing ground for the physics and engineering, it's a good testing ground for the applications. So these are the design drawings, complete with graduate student, as you can see here. And here's the actual reality in the lab. We've actually constructed this system now. And this is Eric Berg, who's taking the lead as a graduate student in my lab, who's taking the lead on testing this system. And literally just 2 days ago, this was the most recent data we got. We're getting the first data out of the scanner, not very exciting yet. It's just showing that the detectors are all working. We're collecting data. We're actually able to reconstruct images of point sources. So we're well on the way to getting this functional, and this will be a great testing ground while we build the human version, the much bigger version. Now, for the human scanner, we set a number of teams working on different aspects of it. There's a lot to consider. So the gantry design is a huge piece of this, how we hold and support all these detectors and the electronics, how we make them accessible for maintenance and replacement, how we cool the system, maintain the temperature in the bore for the patient. Lots of interesting questions here. So we have a mechanical engineering design team working on this part. There's also a lot of interesting questions about how we interface with the patient and how the technologists interface with the scanner. So patient positioning in some ways is fairly straightforward if you want to look at the whole body, because you know where the scanner covers the whole body, so you just know where to put the patient. But if you're interested in optimizing performance for a particular organ, then where you put that organ inside the field of view matters. But I think more interesting are questions like, how do we inject the patient on the bed when they're deep inside this bore of this scanner? So how do we actually get a nice bolus injection of our radio tracer, which we would like for our kinetic modeling, when we're going to have to run a long line through the scanner to do that? How do we get arterial blood samples? Again, if we're doing quantitative modeling, that might be something we'd like to do. And again, with the patient's arm inaccessible inside the scanner, that's not trivial to think about how to do that. And obviously, perhaps less difficult is we need to be able to monitor the patient and communicate with them. And then we have to worry about the comfort of the patient for long dynamic studies. Although we can scan extremely fast with this scanner, there are other scans where we're going to want to look at the time course over an hour or two of our tracer. So it's really important that we design the bed to be as comfortable as possible so the patients don't move. And of course, those of you that do MR will be thinking, well, this scanner is going to be pretty claustrophobic for the patient. And so we have to think carefully about lighting and the ambience of the scanner to try and reduce the possibility of claustrophobia as much as possible. And then I've already mentioned some of the engineering and support challenges. We've got to be able to get in and replace parts if they fail easily. We have to think about the room size. And actually, it turns out the room size doesn't need to be much bigger than it is for current clinical PET-CT scanners, because the throw of the bed already has to get all the way through the CT scanner. So as long as the PET scanner is close behind the CT scanner, in fact, we don't need much more space. And actually, we don't even potentially need a redesign of the bed from current systems. And one thing I didn't make absolutely clear, which I should do, is that this system will be integrated with the CT scanner. It will be a PET-CT scanner. We've been starting to look at the computing resources that are needed, both to sort the data as it's coming off the scanner. So we're going to stream singles information from the scanner, and then we have to sort that into coincidence events. So we've been looking at some of the architectures to do that, and to make sure that we could sort all the data we would collect in one day within that same time period. We've also been looking at how we're going to store that data. We're thinking we're going to be collecting on the order of 10 to 40 terabytes of data a day. And then, of course, we have to have reconstruction times that are also reasonable. And we've already been working closely with Virginia Chee's lab at UC Davis on accelerated GPU-based reconstructions. And we're already getting down. And the nice thing about the simulations is we already have simulated data from this scanner, so we can already work on these aspects and get some benchmarks on the times. So we're already down to 3 minutes an iteration for a low-dose FDG scan, which is already not too unreasonable, and there's lots more work to be done in that area. And as part of this, again, this comes from Virginia Chee's lab, we're very interested in advanced reconstruction methods that really accurately model the scanner environment, but also take into account some of the latest developments in the image reconstruction field. For example, here, an OSEM reconstruction based on the kernel method developed by Jinyi's lab, which really gives far superior signal to noise in this very short, this is a 30-second frame, very low injection simulation of the data we would get in an FDG scan of an adult human subject. And we've also started to look at lesion detection as well. And again, this is all simulated data at this point, but it gives us some idea of the kinds of gains we can get. I'm just going to show you one example here. This is a simulation with a liver lesion here and a lung lesion here. The liver lesion has a contrast of about 3.3 to 1. And so again, when we've got this much better quality data because of the higher sensitivity, you can see this liver lesion is really quite easy to see visually here, much harder here. And here are the contrast recovery curves plotted to compare the EXPLOR geometry that we're working on versus a standard clinical scanner. Now, some of you might be thinking that I made the point about low dose, and we're talking about PET-CT, and I've talked about ways to reduce the dose from the PET, but what about the CT component? And we need the CT both potentially for anatomic correlation, and also, of course, we use the CT currently for attenuation correction of the PET data. So this is a major area of investigation for this device, how we're going to do this, and there's a number of interesting opportunities. So obviously there's a huge amount of work going on in low-dose CT right now using iterative reconstruction methods to dramatically reduce the dose for CT. And so certainly we'll be working closely with our CT colleagues to implement those approaches. We could also consider going back to the old days of PET where we used transmission sources, so an external source of radio tracer that is used as a kind of a poor man's CT, but a low dose, very low dose way to get the attenuation map. It's not a good way to get the structural information, but at least we could get the attenuation map that way. And with the advent of really good timing information, it's possible now to do things that we couldn't do in the past with transmission sources because we can separate the activity that's in our transmission sources outside the patient and the activity that's inside the patient from what we've injected based on the time of flight information. So this may well be a way that we could get very low dose attenuation maps for attenuation correction. And a third thing we're investigating is the fact that the scintillator material that we are proposing to use, and most people currently use, is based on a lutetium compound. And lutetium-176 is part of the lutetium that's naturally occurring, and that itself is radioactive. And so we actually have a radiation source built into the scanner in the detector material. Now, in some ways, this is a nuisance because it causes a background, and in fact is going to be an interesting challenge for some of the very low dose studies we're interested in doing. But it also provides a radiation source that could be used to create those attenuation maps as well. So lots of interesting things to study in this area to trade off the quality of the anatomic information, the attenuation map, versus radiation dose. So now I want to talk a bit more about some of the ongoing detector development as we look a bit more towards the future as to what we would really like to have. We would like to have modular detectors that we can easily swap in and out of the scanner. We would like to push to smaller detector elements so we can get higher spatial resolution while maintaining the depth, which is what gives us the efficiency. We're considering both photomultiplier tube readout, but increasingly looking at the newer silicon photomultiplier technology. We're going to try and incorporate both time of flight and, if possible, depth encoding information, and I'll show why in just a second. We, of course, need to keep the ring diameter large to get the patients in. We really want to cover the whole body. A lot of people have asked, well, why don't you just build a 1 meter scanner? Why go to 2 meters? You get most of the gain. And I think there's two answers to that. First of all, you lose one of the big advantages if you go to 1 meter, which is you don't see all the activity you've injected. You don't cover the entire body. And secondly, the point of this project is really to push the sensitivity as close to the fundamental limit as we can. And then to say, what can we do with that sensitivity? It may turn out eventually that we will develop applications that don't quite need that level of sensitivity and where in a clinical scenario it would be supported by a somewhat shorter scanner. That may be true in the future. But the point is to explore the limits here of what is possible. So we really want to keep the field of view at around that 2 meter mark. And we've talked about this. This is really key with so many detector elements, so many channels of electronics. It's all got to work very, very reliably. Now, I've mentioned this term depth of interaction a few times. So what am I talking about here? So the issue here is that our detectors have to be pretty thick in order to efficiently stop these energetic annihilation photons. And so conventionally in PET, we know which detector element was hit, but we don't know how deep into the detector element the annihilation photon actually interacted. And at the center of the field of view, when we look at this detector in coincidence with this one, it's not a bad effect. So it doesn't really matter too much if the interaction is at the top of the crystal or the back of the crystal. The uncertainty here is bounded by these two red lines. It's not too bad. But now consider a line of response that's much more oblique like this one. And we're going to have plenty of these in this scanner. And now you can see that if we don't know whether the event interacts at the top or the bottom, we have a massive uncertainty in our position. So it's going to lead to degraded spatial resolution. So particularly in this geometry, this is something that we're going to need to worry about. If we can determine the depth at which the interaction occurred inside the crystal, again, we can constrain that and get that spatial resolution back. So that's why we would like to have so-called depth of interaction information in our detectors, which means that we just have to know not just which detector element fired, but where inside that detector element that event occurred. And the other piece is we would like to take advantage of latest developments in time-of-flight PET. And so the idea here is that we're going to time the difference in the arrival of the two annihilation photons to give us position information. And so if we look at these two photons emitted from this point here, you'll see that this one, of course, hits this detector before this one hits this detector because it's closer. So if we can measure that time difference, I can tell you where along this line that annihilation source is. And if I could do it really well, I could eliminate image reconstruction completely, because then I would have identified exactly where this point is in space without the need to reconstruct an image. But to get 5mm spatial resolution along this line would need detectors with a 33 picosecond timing resolution. We have nothing approaching that right now. But even with current systems, we're in the range of, at best, maybe 350 picoseconds or so, 400, 500. There are systems out there with that kind of timing resolution. And so although we don't know exactly where the event is, it's constrained in a much smaller volume than if we have no timing information, in which case we have to assign a uniform probability that it came from anywhere along this line. So this constraint gives us an effective boost in sensitivity. That's roughly, the noise reduction is roughly given by this factor here, where d is the diameter of the object or the patient, c is the speed of light, and delta t is the timing resolution. So the better the timing resolution is, the more noise reduction we can get. And so again, we would like to really push that, because once we've got the solid angle and the detector efficiency, the only way to improve the information in an event is through this timing information. So if we go back to this figure, so here if I have no depth of interaction information, no time of flight information, and I look at this fairly oblique line of response, all I can tell you is it's somewhere in this red volume here. So there's quite a lot of uncertainty here that I then have to try and recover through my image reconstruction algorithm. If I can add the depth encoding and can isolate to a reasonable depth in the crystal where the event occurred, I can narrow this distribution quite significantly. And then if I add the timing information on top of that, I can really constrain where that event came from. So hopefully through this, you can see that if we can develop detectors that can encode both the depth and have excellent timing properties, it's going to dramatically improve our ability to position events and lead to high-quality images. So how do we go about getting detectors that give us both good timing, which already exists, although there's still a lot of development and progress being made in that area, simultaneously with this depth encoding? And that's something that's not been really integrated into commercial systems so far, primarily because there hasn't been a need, because the axial field of view is short. We don't have these really oblique angles in current scanners. So this is something we really need for this project that has not been needed so far for commercial scanners. So one of the approaches we've been looking at is this idea of taking one of the detector elements, a crystal element shown here, and coating it with a phosphor, but only coating part of the crystal with the phosphor, with the idea being that when the annihilation photon interacts, produces scintillation light, some of the scintillation light will be absorbed by the phosphor and then re-emitted. It'll be re-emitted, of course, with the characteristic decay time of that phosphor. And if we have a pattern like this, when events occur close to this end, more of that light will be converted by the phosphor and slowed down, versus at this end, where there's no phosphor, most of that light will go straight into the photodetector and will have the characteristic decay time of the scintillator. So if we take this simple thought experiment here, we have a single crystal, we have the phosphor coating, we have our light sensor here, and I now irradiate this crystal at different depths. And I look at the pulse shape that I get. So this is the intensity versus time. You can see that it's now depth dependent. The tails are slower when I'm in this phosphor-coated region here because some of the scintillation light has been absorbed and then later on re-emitted. Later on, being a relative term here, this phosphor has about a 50 nanosecond decay time. The scintillator has about a 40 nanosecond decay time. So these are fairly small changes, but very detectable changes in the tails of these pulses. So now, by looking at the decay time of the pulse, I can tell you at which depth the photon interacted. And importantly, look at the rise time here. The rise time is what's critical for getting the timing information. And I've not degraded the rise time of this pulse at all by adding this phosphor. So we're able to maintain the rise time and the timing information while getting depth encoding through the decay. Well, that's a single crystal. That data looks quite encouraging. We've now actually fabricated complete detector modules based on this. So here you see the assembly of the crystal array. This is an older detector read out by 4 photomultiplier tubes. We have a light guide to help control the spread of the light onto the photomultiplier tubes. And so the results are quite promising. We're able to detect and see the individual crystals in the array. We get good energy resolution, about 13%. That's pretty competitive. Decent timing for a photomultiplier tube-based detector. This is pretty good, 440 picoseconds. And we've got pretty good depth classification. If we're trying to classify into 2 bins, top bin, bottom bin, we correctly classify 85% of the events. So these are our first steps towards a detector that incorporates both the depth information and the timing. And I just want to point out there's a lot of work going on to further improve timing information, and benchtop systems are able to get, with current materials can get down to around 220 picoseconds, and with some other very interesting materials down below 200 picoseconds. So there's a lot of activity in the field in this area that gives promise for really good time of flight PET in the future. Now I see my orange light is already on here, which is bad news, because I'm still some way from finishing. So let me think about what I want to do here. I'm going to skip that. So just to tell you where we currently are, so as you've seen, we now have funding to develop the first prototype. We've got a lot of simulation and computational work going on. We're developing detectors and electronics, and we have completed a small-scale prototype for veterinary or non-human primate use. I want to spend the last few minutes, though, talking about applications, because this is the reason for developing the scanner. This is not a physics toy. The reason we're developing it is because we think we can open up whole new areas of investigation in biomedical research and perhaps eventually in clinical practice using this technology. So, not surprisingly, we're going to focus on things that involve the whole body, because this is where the big gain is. And so, PET obviously is already used in cancer a lot, and so the question is, how much better can we do in cancer in terms of looking at metastatic disease if we have much better information, or we can scan much more quickly, so we reduce motion. So that's kind of the low-hanging fruit, an obvious, early, easy thing we can look at. But there are other whole-body systemic diseases that we'd be very interested in looking at, and that PET really has not been used for so far. So infection's an obvious one. There's lots of interesting questions about the reservoirs of latent viral infections in TB and malaria, for example. Very poorly understood. I would point out we don't even have the radio tracers to do this yet. So this is a longer-term project, but the idea of being able to look at sites of infection throughout the entire body is very intriguing. Inflammation plays a role in many disease processes. We do have some PET tracers that look at inflammation now. Mostly the studies have been in the brain so far, but there's a huge opportunity to look throughout the body for sites of inflammation. Increasing use of cellular therapies, so the idea of using the immune cells of the body to attack disease, and the idea of being able to monitor this systemically over time using PET is very attractive. Drug development, obviously an area where you use a tool like this, but also looking at toxicology as well. There's a whole area of being able to look at potentially toxic compounds at very, very low masses in the human being to really understand the distribution of those compounds. And obviously for biomarker discovery as well, and new radiotracer development. And then we'd like to believe that if we can go to very low dose, that we can open up new populations for study. So as one of my colleagues puts it, rather than using PET at the end of life, which is what we do, we use it for cancer patients, we use it in dementia, start using PET at the beginning of life, where we can really have an impact on the entire trajectory for that patient if we can start to use this in adolescent medicine and pediatric medicine. So in the last couple of minutes that are left to me here, I'm just going to quickly go through a few possibilities. So cancer, as I mentioned, is one of the more obvious ones because it's where we currently use PET a lot. And so right now, we tend to be looking at lesions in the range of 6 to 10 millimeters or so with PET. And the question is, how far can we push back into the kind of micrometastatic realm? And I think to do this, we have to look at PET in a different way. So we're so used to thinking of PET as being a technique to do hotspot imaging, where we see the spot of the tumor. But a different paradigm would be that if you have micrometastases that individually are not resolvable because we don't have the resolution, but they change the underlying kinetics in the tissue where those micrometastases sit, we might be able to see it, particularly with this scanner where we have very good sensitivity and we can monitor the kinetics over time. So we already know that tumor cells have very different kinetics than the normal tissue. There's lots of literature on this. This is just one example from Martin Lodge showing how in malignant versus benign tumors, FDG uptake, if you track over time, have quite different trajectories. So if you use that temporal information, you have potentially the ability to separate based on the time information, not on resolving the hotspots, but on the time information, being able to detect micrometastatic disease. There's other things you can do as well. You can image much later. I mean, we're confined right now by the decay time of the radionuclide and our sensitivity. We mentioned we could image fluorine-18 the next day. So perhaps our paradigm is going to be completely different, where we inject the patient one day and we scan them the next day. Even at 3 hours out, there are big changes in FDG distribution looking at tumors versus 1 hour out, which is our current kind of clinical paradigm. Here's a tumor that was not seen on the 1 hour scan that popped up after 3 hours. So doing late imaging may let us see a lot more than we can currently see. And then this brings in, of course, the whole approach of how we use mathematical algorithms to pull that information out of the image data. And if we can develop this paradigm for cancer, we can develop a similar paradigm to look at low-grade infection, low-grade inflammation as well. So lots of opportunities there. Total body pharmacology, we already mentioned. We want to look at drug absorption, distribution, metabolism, excretion. That's what it's all about. The tools currently to do this are pretty crude. With this scanner, if we can radiolabel the drug, we'll be able to get all of this information in a single dynamic scan. And the idea would be, and the drug industry is very interested in this, not just in terms of imaging, but in general, they are really pushing to move away their novel drug testing from animals and go into humans as early as possible, because there are just too many failures of the animal models in predicting what actually happens in the clinic. Another interesting area is multi-organ disease. So we tend to think of diseases as being involving one organ. Schizophrenia is the brain. Not true. There's actually a lot of links between schizophrenia and disorders in other organ systems and disorders of the immune system. It's increasingly becoming obvious that many disorders involve multiple organ systems. Yet we have no imaging tools to study this at the present time. We have no imaging markers to study this at the present time. And so one example with the hypothalamus pituitary adrenal axis shown here, which is involved in all of these very interesting and important disorders. So could we start to use a total body scanner to study something like this? We all know the problems of obesity in this country. And so again, we don't have the imaging methods or the tracers yet to study this, to study some of the hormonal signaling that goes on between the gut and the brain, for example. Great opportunity here to do that. And finally, and perhaps most controversially, is this idea of being able to use a technique that uses ionizing radiation in vulnerable populations. So can we get the dose to the point where it's low enough that the potential benefits of the imaging test far outweigh the risks associated with the dose. And so that's this big question here. You know, in animal models, we're already doing fetal imaging with PET and MR, and it's getting lots of interesting findings. I'd love to be able to do some of this stuff in human subjects as well. And so we know that currently we're very restricted by radiation exposure. But when we start to talk about the doses we're thinking about here, this is the annual natural background in a range of different countries. You can pick your country of choice from the list here. And we're proposing that we'll be able to do PET scans with a dose to the fetus. And I'm taking the most extreme case here of considering using PET to image pregnant women. We would be at doses to the fetus of less than 0.1 millisieverts. And so this is less than 2 weeks of natural background. And so at this point, the question is the perception of risk rather than actual risk the barrier? So I'm sure we could have a good debate about that, and that's why I put it as almost my last slide to be a little controversial. So what we hope is that with this technology, with this huge increase in sensitivity, that we can finally realize the full potential of PET in terms of its ability to detect really trace amounts of molecules and follow those throughout the body, where we can really bring back what has been a bit of a lost art in PET, the tracer kinetic principle and the mathematical modeling that goes with that to really extract the most information out of our imaging a series of scans, engage the increasing awareness of systems biology and disease, the multi-organ approach, the multi-systems approach to disease that's beginning to permeate modern medicine. We're very interested in alleviating the radiation dose burden, as we've discussed. And ultimately, we hope all of this will eventually impact on clinical PET. So I'll leave you just with a summary of how we could use that factor of 40 improvement in sensitivity. And if there's time, I'll be happy to entertain any questions. Thank you so much.